Welcome back. Before I turn it over to Arlene, who's going to lead us through a spirited discussion of people with complex healthcare needs who I think as a secondary consideration cost a lot of money. I don't like to say high need, high cost patients. I think that's highly problematic, but patients who have a lot of need. I think, George, we cut you off. You had something, a quick comment to add on the last discussion.
Yeah, and I don't want to belabor the last discussion and cut into the agenda, but I wanted to make a couple comments about the track that we were going on, and I clearly agree with Peter, comments that you made, and Karen, things that you said, and others, that a lot of our work in the future is going to be dealing with the social determinants of health. And the comments I wanted to make is we have to recognize that when delivery systems get out there into taking on that type of focus, it's messy. It isn't precise. There's going to be a lot of variation in the way that different organizations, you've gotten responses to your RFP, and that's great, and you're going to see a lot of variation. There is some fundamental concepts that we have to recognize, and some of the concepts are that while it's messy, there is a wealth of agencies in all of our communities across the country that are working in areas that have a big impact on the social determinants. We don't have to recreate that. What we have to do is we have to figure out a way, the delivery systems, AHRQ and ourselves, to plug into what already exists in the communities that we are in. So that's critical. Lots of variation. It's going to be very imperfect and messy. I use the term messy. Probably initially we're going to have to pursue concepts that we think might have some positive impact on the cost of care and the delivery of care, but we're not really sure. And most importantly, we have to be satisfied with sitting at the table with other agencies that are doing work in education, in the police departments, and the fire departments, and the school systems, and all the other infrastructure within our communities. So just keep in mind it's messy, and we have to be satisfied with taking a back seat.
I also want to just make sure we know that Andy Masika is on the phone, who chaired the last meeting and couldn't join us in person today. So welcome. We won't make you go through the tie exercise that we did in the interest of time. So Arlene, you're going to pose a bunch of questions. I'm going to be timekeeper, facilitator, call on people, interrupt, and whatever. Okay? That good? Thanks.
This is May. She's 52 years old, and she's one of about 100 million Americans. This is May. She's 52 years old, and she's one of about 100 million Americans living with multiple ongoing health problems. May and her husband take care of her father and their children. She works full-time, and today she's got to leave early to catch the bus for a medical appointment. May is tired. Patients with multiple chronic conditions have frequent healthcare appointments that can complicate an already busy schedule. The amount of information coming from many sources can be overwhelming, confusing, conflicting, and impersonal. Different clinicians offer different treatment plans and advice, and there's often little communication and coordination between them. Clinicians do not have the information and tools they need to best support people with multiple chronic conditions. As if May's hypertension and arthritis aren't hard enough to deal with, she also lives with depression, which comes with yet another appointment and another plan for treatment, adding to a life which is already complex enough. But what if there were just one care plan, created just for May and with May? One plan that would treat her as a whole person, rather than focusing on each of her separate conditions. A plan that's created by her care team, with May and her family, that's easy to understand and is agreed upon by everyone. Like everyone, patients with multiple chronic conditions deserve a better healthcare system, one with less confusion and better coordination between clinicians. Working together, we can transform the healthcare system to serve the whole person with all their complexities. It will take everyone, clinicians, researchers, policymakers, patients, and families, working together to get it done.
We're not just talking about high needs, high cost patients. So there's a whole continuum, and I'll talk about that a little bit later. But I just wanted to start because really most people have multiple chronic conditions. I think Gopal gave some of these stats before, but it's 1 in 3 Americans. It's across the lifespan. It's at least 4 out of 5 Medicare beneficiaries. I think we're undercounting. And that really the way we deliver care does not meet the needs. You know, it's fragmented, it's burdensome. It doesn't work for clinicians, for patients, for their families, for anybody right now. On top of that, low income people and people with racial and ethnic minorities develop multiple chronic conditions at an earlier age and are likely to have more. And so they're at the same time, they have less access to care and might have more trouble navigating the system. So there's really huge opportunities, you know, to improve care. And just think about what we're doing. We have a system that's based on treating diseases, which we've learned to do quite well. But people with multiple chronic conditions account for 64% or 2/3 of all visits, 70% of all inpatient stays, 83% of all prescriptions, 70% of all healthcare spending, and 93% of Medicare spending. So it really is a major challenge facing improving care delivery. So I'm going to stop there and go back to the May video and just ask you, because multiple chronic conditions, honestly, is a horrible word. We want to figure out how to talk about it, how to make it a soundbite, how to make it compelling and engaging. But it's like anything else, like when you see it, you know what it is. And I'm just curious from the NAC members, like, do you have examples, like from your personal life of yourself, friends, family who have dealt with it and how the system hasn't worked?
Okay, Yenling.
I jumped in. My dad had COPD, and I'm sorry. Thank you. My dad had a COPD, and you know when your lung doesn't work well, your heart doesn't work. So he had that, and I went to every doctor's office with him, hospital stay, and I found out that early time when I was my dad advocate, I found the care is really not connected. When I go to pulmonologist office, they talk about how to treat it, but they didn't address the heart. Sometimes they give medications not good for his heart. So that I totally understand. I think this is a great thing to do for the agency to look at, to treat a person with a whole, and the care team will work together to address the health care problem, multi-condition in a whole person's way. So it's my experience.
Thank you. Arlene, I have personal examples, family examples, but I think a bigger example is a message that I got yesterday while I was here at orientation from my son-in-law, who said, my assistant has a mother who is 83 years old, who is seeing 2 different caregivers, one for her COPD, one who's her regular doctor, who says she has nodules on her lungs. They're telling her 2 different things. She's 83 years old. She doesn't know what to do. She asked her daughter. Her daughter doesn't know what to do. Her daughter asked me. My son-in-law is an attorney who works in something totally unrelated to healthcare, but he's also a registered nurse by background, and he didn't know what to do, so he texted me. I haven't responded to him yet, other than to say I'll get back to you. I mean, yeah, it's real. It's everywhere.
mean, from my experience, I think one thing that's lacking in these discussions, and I think it's the health delivery caregiver side fault, partly, is that, is that people are generally, and I include myself, because I could give a story just from this last weekend, I mean, live in denial of conditions they have. Now, if the conditions are particularly acute, they can't deny it, and they get forced in. But I could describe what happened to my mother, who died a little over a year ago, and frankly, she was almost 92, so she was going to die eventually. But she didn't have to die the day she did. And it wasn't the fault of the caregivers, although she had a terrible internist who did not provide the right care. But, you know, if she'd gone to the doctor 4 weeks before she did, you know, it would have been different. But I think there are many people, and I think partly it's the system's intimidating, the system's time consuming, and the system is not welcoming to questions and inquiries. And people, you know, don't want to think of themselves as being sick. But it's very difficult to me. I mean, I'll be honest. So I wasn't here at dinner last night because on Sunday morning, you know, I was a maniac on my Peloton, and I ended up collapsing. I could tell the whole story. So I spent Sunday and Monday in the hospital. And, you know, I'm fine, I'm here. And I had every test in the book. But I can tell you, even I'm pretty familiar with all this stuff. You know, it was not a great experience. I didn't feel comfortable. I didn't feel informed. And like I was asking questions and stuff. And the night in the hospital was horrible, even though it was a very nice hospital and everybody was very nice to me. But I think the system is not designed to be people-friendly. I don't know about this population health stuff and all this kind of stuff, but it's not a people-friendly system generally, even if you have caregivers that are caring. I don't know. What else to say about that?
Barbara?
So I think we probably all have personal stories, but I want to just share a little bit about some research that we have mostly finished in Massachusetts. Is based on a survey of started with a survey of 5,000 Massachusetts households, so reaching out to the general population, trying to identify, first of all, a cohort that had experienced medical error recently. But in addition, then we did a recontact survey of that group and asked in-depth questions, including 10 open-ended narrative questions, you know, starting with, well, you say you had experienced medical error, in your own words, what happened, and then also asking them about what their perceptions of what the contributors were to these adverse events. And there's some really interesting key themes that have emerged. And, you know, one is that, I mean, first of all, there's usually a cascading effect. When you have a serious preventable harm event, it's usually not just one thing. It's a whole cascading set of circumstances that results in harm. And what the patients, and these are people, and this is from the general population, and so we have their demographic information, but I can tell you it's very, very diverse. So it doesn't matter if you're a highly educated, empowered, you know, you're a healthcare executive, or, you know, if you're at the other end of the spectrum, they're basically picking up on the same set of observations, which is that there's, you know, sort of the lack of communication across the care team, even within an institution, not just even in care transitions across institutions. And then another really interesting theme that they would just, sort of people would express is, you know, I thought that they all had systems for this. Like they just assume that there are fail-safes. They assume that healthcare providers have systems that allow them to communicate important information amongst themselves, and they can't believe it. I mean, that's what's coming through the narratives. Like, how could this be that in this day and age there is such little coordination, and that this is what's causing not only a bad experience for me, but it's resulting in harm.
I just want
Yeah, we could
with
move
you,
on,
how
yeah.
much time do
No,
we?
we probably should move on and then
Okay,
get
because
some,
they're
yeah.
powerful narratives.
Yeah, this is
but-
great. And it's funny, I'm reminded of my mother who had multiple conditions, was frail, and my brother, who is an engineer, came to visit during one of her many hospital admissions, and he just looked at me and goes, this makes no sense. This is just a system. You have to connect the parts. And I think it's the same thing. I mean, even though I'm a geriatrician and I'm very knowledgeable and I was plugged into her care team, it was near impossible to coordinate her care. So it affects all of us. Yeah. So I'll move on and hopefully we can hear some more of these stories later. So, just some, numbers that basically in terms of readmissions, the first graph shows the percentage of people with multiple chronic conditions. So you could see only 14% of Medicare beneficiaries have 0 or 1 condition. But the 98% of readmissions are with people with multiple conditions. And of the 14% of people who have 6 or more chronic conditions account for 70% of all Medicare readmissions. And I would say that our disease focus, we've had huge steps in improving care in a whole lot of areas, beta blockers after MIs, but then, or, time to hip fractures and bundles. But what happens is actually, if you look at the reasons for readmissions, people are not, even if you do well, covering, treating the cause of their index admission, something else is going to go wrong and they're coming back for other things. So you're in the hospital for a heart failure, you're in bed for a few days, you get weak, you go home and have a fall and have a hip fracture, even though you got all of your right care for your heart failure. So it really is a complicated problem. And then I'm just going to move this a little closer so it's easier. The other thing is costs. The 1/3 of beneficiaries, basically 14% of people who have 6 or more chronic conditions are half of Medicare spending. So, I think you all know this, and this, just illustrates that. And my next slide shows of the common conditions, how many people have multiple conditions. And this is a lot to look at, but even something like simple, like hypertension, only, 6% of people with hypertension only have one thing, and 23, a quarter of them have 5 or more. So it's just even for common diseases. And then if you go down and look at something like heart failure, over half of people with heart failure have 5 or more chronic conditions. And it was interesting, I'll tell you a little bit more later, we're doing a series of stakeholder interviews, to get information and try to inform the MCC initiative. And we were talking yesterday to Paul Batalden, who many of you might know, who's brilliant. And basically what he told us is, we have figured out how to take care of diabetes or, heart disease or whatever, but we haven't figured out how to take care of Janice, right? Or May. And I think that's where AHRQ can uniquely contribute, is how do we put all the pieces together. The other thing is this is really a syndemic. We have a rising numbers and a rising prevalence of multiple chronic conditions. And if you can think about it, we really don't know how many. I think all the numbers are underestimates, and I'll tell you about that in the next slide why. But this was one study that used N.A. Haynes data, and they found 58% of the overall population, not the elderly, has multiple chronic conditions. And why is their estimate so much higher than anybody else's? Because they included obesity as a chronic condition. So it's really with our definitions, and in their study, 93% of Medicare beneficiaries had multiple chronic conditions. But the other thing is it really does affect the life course. It's not just a thing for older adults. I'm a geriatrician. That's my area of focus and interest. But actually, when Paul Batalden gave us examples yesterday of systems where it has worked, he gave the example of kids with cystic fibrosis, who then have diabetes. So there, it does affect the life course, and it's something that we need to, and I think that's where AHRQ is unique in being able to take that life course approach. So, so what are we talking about? I think definitions are key in the language for what we're talking about. Is it multiple chronic conditions, multimorbidity, burden of illness? So multimorbidity is a term often used synonymously with multiple chronic conditions, including those with more than one physical condition, more than one mental health diagnosis, or both. And I could say the disease counts. The only disease that sometimes gets into that count is depression, and other mental illnesses are not included in those counts. And others use the term multimorbidity to include additional factors that contribute to the burden of illness. And this is things like severity of disease, functional impairments and disabilities, syndromes such as frailty, social factors, homelessness, food insecurity. So what we're really talking about is, how is a person experiencing their needs and their health that takes into account all of this. I have some questions next, but I'm going to skip ahead and show you a slide that I was going to show you later. So, people think automatically about high cost, high needs, and there hasn't been a lot of talk about prevention of multimorbidity. And you think about it, we have this endemic because it's the same risk factors, causing these multiple diseases. So I think there is an opportunity to step back, address the social determinants of health, work with public health to really prevent multiple chronic conditions. So what I've conceptualized is 3 strata. And I think, later in the conversation, we could talk about where AHRQ should focus or where we could contribute. But really, we need to prevent, prevention interventions targeted at reducing the prevalence of common chronic risk factors with a particular focus on interventions to reduce likelihood of those at risk. And so those are the things people we know already have multiple risk factors: smoking, sedentary, poor diet, etc. And it doesn't necessarily have to be the health system that does it, but we need to figure out how to partner effectively to move a little bit upstream and address prevention of multiple chronic conditions. The next group of people are people maybe like Chip that you were talking to, like they don't, they have a little high blood pressure, maybe some type 2 diabetes that's mild, a little arthritis in their knees. Oh, I'm fine, right? And these are the people I targeted as rising risk. They're just one incident or one event from being complex. So what can we do to better integrate, manage, coordinate their care to keep them as healthy and active and independent as well as possible? And then the last group is the high risk, who I'm sure you've heard a lot about, because that's where a lot of the focus has been, is the high needs, high cost patients who, are in and out of the hospital consuming, disproportionate share of the resources. But the bottom line is if we don't move back and deal with people earlier on, you're always going to be replenishing those high risk, and you're not going to solve the problem. So I'm going to go back now to the questions. So, from your perspective, I'll lay them all out and I'll let you, just jump in with what you want for time. But from your perspective, what is the scope of the problem? How should we talk about this? If it's not MCC, what is the language we should use? How is this issue being addressed or talked about? Is it something that you're confronting in your systems and organizations? And, for you, from your perspective, what are the key problems as it relates to people with multiple chronic conditions?
Edmondo.
Excuse me, Edmondo Robinson. So a couple things to point out here as we tackle this issue is, and we're thinking about it from a managing populations, including at risk in terms of financial risk around managing those populations. A couple things. One is the healthcare delivery system, excuse me, is so ingrained in being designed for and by the healthcare deliverers that that transformation to actually being designed around the needs of an individual person and not their disease, as you mentioned, Arlene, but around the actual person, that's a big transformation. And so part of how we think about that is how do you even build the systems that are designed and aligned to actually care for individuals. So, I mean, yeah, we throw in social determinants and you've got to think about bigger things, but really at a fundamental level, how are you designing your systems to actually care for an individual? For example, in your example, little cartoon there, yes, they come in, they got to see a cardiologist and a primary care doc, and maybe now they can see a psychiatrist. How do you design, how do you take the concept around the cancer care and multidisciplinary clinics? How do you build something like that around chronic disease, for example? The other challenge that we're having, it's probably along the same lines, is given the volume of patients that we're dealing with here, the question becomes, how do you scale your approach? So your part of what we're trying to get at, again, if you're talking about the size of the population, it's, it could be 50% of our total population. We're talking about multiple chronic illnesses. How do you leverage digital? How do you leverage, artificial intelligence? How do you leverage a lot of the innovations that are coming out to manage these kinds of populations? What does that even look like? How do you know how to approach it? How do you know where the evidence lies? How do you know how to actually deliver that care? How do you train up your providers to be comfortable with and even experts in leveraging these technologies? So it really is kind of, to me, a fundamental design of your care delivery model and system question.
Okay, thank you. Let's go Rahul, Jerry, Tina, and Greg.
Yeah, I won't repeat what my esteemed colleague just said because I agree 100% with that. When we surveyed our groups to look at how they wanted us to use our data asset to help them improve care, really fell into 4 domains. But they all bleed together. One is the total cost of care. The second is practice efficiency. The third is these high-risk patients. And the fourth is quality and quality measurement. And what they told us is that they want to work together using these benchmarks to help them figure out how to take care of these high-risk patients in a cost-effective way within their systems. That's the issue that they're struggling with. In order to move towards value and to move towards risk. I'll just make one other point. So I would say, first of all, on our medical group and health system priority list, number 1, just because of the cost implications and the practice efficiency. And I'll just make one other comment as a primary care physician. I think this is also a contributor to burnout. When we're having primary care physicians 15-minute office visit without the resources, especially many of them working in small groups or small practices, without the resources and the care teams that are necessary to take care of these complicated patients, without the social workers and the behavioral health and the pharmacists and all the other care teams, they're swamped and they're overwhelmed.
So one thing I want to throw in there is we often talk about 50% what the population is. I would have us think about, because we have colleagues here from other agencies as well, what if May was a veteran? Would the care be different for her? And because there's some models exist, I don't think we test them and look at them in a way, again, going back to that primary care provision of care, which may actually be worth looking at from that perspective. Because I think the more we have multiple chronic conditions, there's more value to understanding the return on investment for at-risk population and rising risk populations. If we do that, study that direction, return on investment, I think we're going to be able to invest in that. So what typically happens is vaccines comes to mind as pretty much the most well-studied. We don't really have good return on investment, and therefore we do not invest into the at-risk and rising risk, and therefore we end up spending most of our dollars on high-risk populations. So there's a reason we do that, what we're talking about. And the reason for that is we have not made a really good case for investing in the at-risk and rising risk. So that's one piece. The other is that population has to be served also, we have to remember, in a culturally competent manner. So that's the other aspect, is because a lot of times, I go back to this person, would not understand a lot of that because the information delivery isn't happening in a way that it is she could understand. So I think that's critically. And the third thing I'll just mention is the scope, which goes back. We really have to have those conversations. Do we need a cardiologist for every time somebody has hypertension? Do we need a psychiatrist, or is it really these are primary care problems that needs to be enhanced and again invested in a way to primary care systems, which is not just primary care physicians, also all the other levels of care that need to happen in order to make that happen. And lastly, one way to look at this problem is through the lens of prescriptions, because there are states that have 18 to 22 prescriptions per capita, per man, woman, child, and infant in those states. So I think we're in a situation where we're really happy as a physicians or other providers to write a prescription for the problem rather than to spend time, because that's not the way we get reimbursed and valued. So I think one way to look at it through the lens of how much prescribing occurs, which actually then results in a lot of these other drug interaction and other complications as well.
So I agree with my colleagues and what's been said, and I want to take it back just one step, because when we talk about these patients with chronic conditions, certainly in our hospital, we don't really know how to treat them. Why? Because they're excluded from clinical trials. We don't know which therapies work best when somebody has these multiple conditions. And so there's really some opportunities, I think, to develop sort of, what is this patient population? What works best? What do they want? How do they value care? If you have somebody who has diabetes, hypertension, foot ulcers, and obese, what's the best care model and what's the best drugs that work for them? I think there's opportunities when we start thinking about all the real world evidence that's becoming available. And these patients, we have this information on these patients with chronic conditions, chronic polypharmacy, et cetera. We haven't had a research agenda that really leverages that information to focus on this population. I think it could be a key agenda item for AHRQ to think about.
So I'm going to jump in. I'm going to jump in for a second there, because that was my next slide. It's the evidence-free zone, right? So we have great guidelines, and when people are well and have, single conditions or mild to couple, thus the guidelines apply and know what to do. Actually, I have to credit Carolyn Blaum. This is from work that she's done with Mary Tinetti to develop patient priority care. And on the other end of the spectrum, we have people nearing the end of life where you make these decisions, what applies and what do we stop and what should we do. The vast majority of people are in the middle in what I call the evidence-free zone, because these are the people who are excluded from trials. And so there's a whole agenda for NIH on, what is the clinical management and how do you address this? But there's a whole delivery system problem in there. And there's other people. So the chronic care model was the first model to kind of say, look, we need to be proactive, and it takes multiple moving parts to manage chronic disease. And there's other people. So, Mary Tinetti and Carolyn Blaum have developed patient priority care, which is an innovative approach to this. Actually, Victor Montori, who used to be on the NAC, who's sitting here, has developed minimally disruptive care. So we need to think about these models and how do we implement them, scale them, and apply them to actually provide better care. So I just had to jump in there because I was like.
So, Greg, go ahead.
So I'll be quick, but so I draw my comments from Centers for Medicare and Medicaid Innovations project that we've been leading for the last 6 years, and we have 2 more years to go. The part of that project was to successfully reduce avoidable hospitalizations in the community, specifically in nursing homes that where people were living in St. Louis. And so we've been very successful at reducing those, and there are really most of these people have multiple chronic conditions, and we've been tracking about somewhere between 1,300 and 1,400 people over 6 years and managing their care. And there are really 6 points, some that you actually just mentioned, Arlene. We think that what's helped us reduce rehospitalizations and help keep people in the community is by just doing fundamental assessments that are evidence-based and providing resources so people know what those assessments are. And that helps them to detect earlier the illnesses that are happening. And early illness detection is really an important area of work. And early illness warning systems might be decision support. It could be other types of things that have been mentioned before. And then in those settings, we've put people in there that provide a higher level of care. They cost more, but ultimately, when you're reducing the cost of the hospitalization, they're receiving a better quality of care, and they're able to stay there. So we're shifting the cost a little bit. It's not cheaper exactly, although it does reduce the hospitalizations by modeling best practices and access to best practice and evidence. And part of this, and Beth Ann and I were talking earlier, is about building stakeholder networks. Our stakeholder network within those 16 hospitals and the 5 surrounding or nursing homes in the 5 surrounding hospitals is absolutely critical for us to be able to share the care across those settings, create systems that are interoperable, build innovation, and to share the responsibility of the care for those 1,400 lives across those settings. And we focus on end-of-life care and medical decisions, and we focus on incentives and payment to accept risk. And not everybody wants to work to get payment. It's interesting what motivates people to actually bill when they can for preventing a hospitalization. Sometimes they don't want to, or they don't have time to. So you could put systems in place, but they don't always respond the way you think they will. And then the final thing is we've found that feedback tools, helping people understand where they are competitively compared to other organizations, and being able to talk about that among these stakeholder groups has been hugely helpful in helping them to adopt the risk management approaches to reducing the hospitalizations and keeping people out in the community.
Arlene, how are we doing on time? We
So
have,
what time do we have to finish the session?
well, we were going to go to lunch at noon, but then we come back. So the
Yeah.
rest of the day, actually, we're going to shorten lunch to 40 minutes.
Okay, so let me,
But we have these 3 people. Do you want to hear
why
from
why don't
them?
why don't we hear from the last 3 and then
Yeah,
I'll
and maybe
go on.
they could help me deal with something that's been troubling me as I listen to this. We have a proliferation of bundled payments that are all condition specific, that clinicians, your members, are struggling to get paid for or penalized. So maybe if we could have some reflection on that as well, because that's a big disconnect for me cognitively. So who had their card out? George and Pat, and young Lindsay.
So I'll just try to be brief. I was listening to this problem with multiple chronic conditions. I was thinking about how AHRQ funded some of the first decision tools, really, for patients to decide whether to pursue one treatment or not for single disease focus. But maybe, given some of the comments that Tina made, that these people are not part of clinical trials, that this is a place for machine learning, the computational methods to start to develop tools in a much more complex way rather than what we did early in this early evolution of personalized decision making, so that these could be targeted to physicians to aid them. What do I need to know about this patient? And if I take this treatment course, what's the cascade effect of these various probabilities? And that is the place for these kind of tools and computational methods to better understand the probabilities and downstream outcome in a multiple comorbidity situation. Otherwise, you do end up with this primary care physician with 15 minutes. He needs to be able to walk in, or she needs to be able to walk in and look at the sheet. What do I need to know about this patient?
this treatment course is going to lead to these outcomes, this cascade effect, what's most likely to happen, and to have that mapped out. And when I think about the technologies that we've developed in every other areas, Siri, those kind of things, to be able to ask a question and get these answers, we should be able to apply those to this kind of situation as well.
A couple comments about some things that we found to be very effective. One critical issue, and we're talking here about a broad, everyone in the country. I mean, your data is broad. When it comes right down to delivery systems, things become more narrow, and we have more defined populations. So a delivery system with good information technology has defined populations. And there are a lot of ways of segmenting those populations. You can segment populations by the chronic conditions that a patient has, but you can also segment the population by the payer for that population, for that segment of the population. In other words, we can segment our population of patients in our system and in our region by employer. So we can identify all the patients from a specific employer. We can segment the population by those that are coming to us through Pioneer and NextGen, CMS patients, et cetera. And the reason that's critical is that when you segment the population by payer source, you're segmenting the population by an organization that can influence and partner with you in overcoming the cost for that care. So in other words, people within an employer group is a segment. There's a bunch of people in that group with multiple conditions, and we can identify them through that employer and influence that population through that employer. In other words, leverage our resources. And I would agree with those of you that have said, well, then what? You know, you have this data, you've segmented population, you know basically the quadrant that you laid out, Arlene. You know where people are, and you've got very small percentage of the population consuming a lot of the resources, a lot of the financial resources. And then identifying what can we do? What can we do to better manage that care and certainly improve the patient's condition, but bring down the cost? So the tie here is between segmenting a population, identifying those people and being able to track them well through your information technology, identifying where are they spending the money, where is the cost going, and what can we do in the primary care clinic and the specialty clinic to help more efficiently manage that patient population. So I'm kind of shifting the discussion from kind of broad clinical situation to a more financially oriented situation.
Yunling, and then we have Andy who wants to say something on the phone.
Thank you. I just want to very briefly, when you come down, when the care is really come down to in the hospital or clinic, it's really down the personal level, each individual person. That's how the care delivered. So I just want to say briefly from the health consumer's perspective, quite often we hear is lack of a coordinated care. It just seems like it's very universal. And lots of factors contribute to it. Communication among the team, healthcare team, communication between the team and the patient and families. And also how the records are shared. Different records, written records, electronic records, sometimes they're not shared. Diagnosis were not even communicated with the next team member. And also, what is the patient and family's perspective in this chronic management, how to prevent it down the road, and what they want to prioritize their care. I think sometimes their voices are missing, in this type of management. And also the insurance thing. And you have a, like May's example, you go to psychiatrist care, and you go to other type of care, and different insurance, whether cover or not cover, sometimes make it very complicated for consumer to navigate through all this. It's all make very complex to manage the care as a whole.
So I'm going to run through the rest of my slides quick. Oh, Chip, oh, sorry, Andy. Oh, hi, Andy. I'm supposed to be where you are.
So thanks. And just tying back to Don's comment, and then also I think more broadly, sort of how I think the NAC can help AHRQ coordinate the different activities. So, and this relates to Don's comment about bundled payments. So, as another, I was recently involved in an AHRQ-led group related to the evidence-based evidence practice centers, and how do we make the systematic reviews more useful? And one of the key topics that came up as a priority was understanding the chronic disease and specifically bundled payments and the different implications of managing that population within bundled payments. So I think that just sort of highlights that there is the evidence gap. People are very interested in that. And just again, in terms of tying the different swim lanes that AHRQ and different pieces of work that AHRQ has going on, I think that is clearly it was an opportunity that another group identified in terms of what would be a high yield focus for the EPC efforts. That's it.
I think this, and the issue just was mentioned, and I think, and Arlene, you brought it up. I think payment is critical here, and when Don sort of brought up bundling, I mean, I think at the end of the day, the dilemma we face is we really only have two alternatives in payment. We either have fee-for-service or we have capitation. All this stuff about ACOs, and we can go on and on about all these different alternatives and experimentation. At the end of the day, if you examine them closely, fee-for-service is still at the base of all those things. And you create these artifices that replicate bundling. But at the end of the day, you're going to chase your tail because you still got fee-for-service at the base of it. So if you really want to get at this, frankly, from my point of view, and it's not necessarily the point of view of my members, but would be, everybody should, Alan Enthoven was right. Everybody should be in HMOs. But it was the notion of everybody needs to be under capitation, because you're going to have to either figure out how to make all this stuff work under fee-for-service and stop lying to ourselves about trying to invent all these new things, or you're going to move everybody to capitation. I mean, that's really the only alternative, I think. It's a little bit radical to say, but I think that's really all. And the experimentation to me is very destructive to the system. I mean, we're not going to have ACOs 10 years from now because they don't work. I mean, they work where they're good systems already. You can't do all this stuff in fee-for-service. Anyway, that's just my 2 cents.
Okay, so I'm going to, so we've been thinking about this for quite a while at AHRQ and pulling this together, and we actually developed a vision of where we would like to see the healthcare system go, and I think it touches on a lot of the conversation around the table. So we would like to see a sustainable healthcare system that delivers high value, coordinated, integrated, all the buzzwords, patient-centered care in primary care that optimize individual and population health by both preventing and effectively managing multiple chronic conditions. And I purposely will not show you to the end kind of some of the things we're proposing, because I don't want to, I want to get more open-ended ideas. And so this is how I see multiple chronic conditions. Given it's a lion's share of what we really do in healthcare. But it's also, if you think about it, we also have the blind man and the elephant, right? Everybody comes at it from their perspective. So the cardiologist sees May one way and the psychiatrist sees her another way in the primary care. And nobody's putting it together to say, who is May and what does she need and what does she want and how are we going to, help her get it? So, And I was really happy, Jerry, to hear you talking about primary care. I'm actually a primary care doc. I practiced for many, many years. And I agree, the way we organize care makes it impossible. And that's why there is so, and we need to build and design systems that allow, primary care doctors to adequately function and really be the home and the, for coordinating care. And I'll go through a couple of different models. But a lot of people say like primary care is dead because we're going to have, retail clinics and we're going to have you go online and see somebody. Well, that's fine if you're healthy. But I'd say that primary care really has a critical role in taking people who have, multiple issues, whether physical, mental, or social, and, and need that help navigating the system. So do we need to redesign primary care to make it feasible to do that, and what will that take? So, and if you look at the shared principles of primary care, which I'm sure you all know, I'll just read them out. Person and family-centered, continuous, comprehensive, and equitable, team-based and collaborative, coordinated, integrated, accessible, and high value. That's really the needs of people with multiple chronic conditions. And AHRQ did a lot of the foundational work on creating primary care. And it's not going to be one physician who does this. It's going to be a team integrated. And, you can see many of those, really that whole person orientation as central to primary care. But once you have multiple conditions, you need more than a home, right? It takes a village. So you need the medical neighborhood. And I think we've had some conversations about this, but it's sort of how do you integrate primary care on one side with community services and public health. We shouldn't reinvent the wheel, but we certainly can partner and align our efforts. And then on the other end, how do we integrate primary care with specialty care, acute care, post-acute as people transition and out, home and community-based services. So there's a real role of, building a medical neighborhood around the patient-centered medical home. But even that is not enough. And I've just called this a health community. And I think this is what people were talking about earlier, things like housing and, access to healthy food and transportation. I don't think that the medical system should, reinvent the wheel, but and there's a lot of people working in this space. So how do we work effectively to really share, services and have people work on what their expertise is, but really aim it all at improving the health of individuals and populations. And I sent a couple of background materials. I don't know that anybody has had a chance to look at them, but one of the things I sent was a paper, actually, Victor and I and the team at in my Center for Evidence and Practice Improvement had published in January in the Journal of General Internal Medicine. And we called it the Care and Learn model, because we think there's, and we basically said these are the two functions of the health system. Primary is caring, and there's a lot of research on, doctor-patient communication and shared decision-making and how to care, cultural, competence, how to care more, effectively. And then the other, trend where things are going is the learning, as kind of the learning health system, the move to, evidence, synthesis, implementation, and then generation from the practice. So we put together a model. We did this to think about how to frame our programs and set priorities. But, briefly, it's basically, it starts with a situation or a problem. And that could be a problem of an individual, a family, a community. But that most of the time people are in their own, their community and their neighborhoods. They're not in the health system most of the time. They come to us when they need help. And then, all the tools we have of evidence-based practice, we assess the problem, we use evidence to solve it, we organize a response. Sometimes we don't organize the response as effectively as we could. We adapt it to the needs of the person, and then we produce evidence. Did it work or did it not work? And then we can use that to evaluate what we're doing and complete the cycle. So, we would really like to see research that aligns both those caring and learning functions of healthcare delivery. And I think this is my last slide, and this is from David Dorr, who's at Oregon Health Sciences University. And he developed something called Care Management Plus, which is a way of rationalizing care for people who are more complex. But I just really like the image. At the first, it's like Mrs. Vieira, and she has, multiple specialists, a caregiver. This is what her paths are. They're all tangled and confusing, and nobody could follow them. And if you rationalize it and put the primary care team in the center with a care manager, you can clean that up and make a rational approach to delivering care. So I see we're coming on lunch, and this was going to be the last question that we discussed in this session, but we could move it over into the next session. And so what we have actually, spoiler alert, we've put together a proposal where we think we could develop a research agenda, and I'm going to show that to you at the end for get your feedback. But we'd like to hear from you first is what kind of research tools, practice improvement strategies, data and analytics are needed to achieve better outcomes. So just, maybe people can think about this, and then when we come back, I just have a few more slides, and we could really have an open discussion.
Yes, so that's great. We're going to take a break. It's probably not enough time to get
Yeah.
into this now, but I do want to use the chair's prerogative to be provocative. Prerogative to be provocative, right? Profit, whatever I'm trying to say. So you put up a slide that makes the assumption that primary care is the medical home. And one of the exercises I've been doing lately is saying, what if it weren't? You know why a camel has two humps? Some camels have two. It's because they piled more and more baggage on the one hump until the middle collapsed, and now the camel has two humps. So you've just, in that model, put a lot of stuff on the medical home, and we have multiple models and efforts to make the medical home, CPC Plus, to make it reach out and promote with partners community health. And I just want us to think through, what if that weren't the model? What if that is wrong? So what really set me up on this was when you quoted Paul Batalden, you said, look at cystic fibrosis. Cystic fibrosis is exclusively run by cystic fibrosis specialists sitting in academic medical centers around the country who collaborate, and primary care plays a minimal role in their care. They don't get immunized, in fact, sometimes, because the CF people forget that they need immunizations. They never see their primary care physician. So we have to somehow reconcile this. It's not just a compact between an extended community-oriented medical home and specialists. There's something wrong with that assumption because we keep piling on it. Physicians are burned out. Jerry's members are up in flames with their burnout. So I'm not going to say that's not where we want to go, but I would like to at least see people reflect on what's wrong with that picture, okay? Why is the elephant sitting in the middle of the room and not being recognized when it comes to primary care? So with that, just for you to digest over lunch and come back to answer the question, which is a really important question that Arlene asked, but with a little bit of disruptive thinking and maybe a little bit of edge, that would be great. Because ultimately, if we tell AHRQ to do the predictable, but the predictable turns out to be not the way to go, they're going to end up in a rut. We don't want that. So I'm sorry. I hope that's okay. I didn't prepare you for that. But why don't we have lunch? Why don't we have a 40-minute lunch? And if you don't mind, to remember to get your pictures taken. I just looked at my picture again. It's so captures me. So please go and do that. And then get your Korean noodles.